All right. Sorry for the delay. We had some technical issues up here, but probably good to start a couple minutes late given what's going on 225 and the rest of the highways right now. So our first speaker this morning is Dr. Emily Malgor. Just a show of hands, who here has not taken care of a patient with a PE? Raise your hand. Okay, that's what I thought. So Dr. Malgor is an assistant professor of surgery in the vascular division. She did her undergraduate training at Dartmouth, medical school at New York Medical College, general surgery training at Stony Brook, and then a vascular fellowship at the Mayo Clinic. She was briefly on faculty at Oklahoma, then Centara, and we were lucky to recruit her in 2019 to the University of Colorado. She is a very busy and excellent vascular surgeon, and I know this firsthand. She's been in the OR multiple times to help me out on tough cases, and our patients have done extremely well. She is publishing very well and is known as an excellent teacher, and she brings up a very important topic this morning. In general, our department has a higher than expected rate of DVT and pulmonary emboli. And this is something that we've been working on over the last 10 or so years. We've gotten the rates down a lot significantly through leadership from some of you in the audience, but we have a little bit more to go. And I think the more we know about DVTs and pulmonary emboli, the better off our patients are and our department is. So with that, I'm going to ask Dr. Malgor to come up and give her talk on submassive pulmonary emboli. Are we doing enough? Thank you. You're all set.
Thank you. Thanks for that introduction, Dr. Schulich. Good morning, everybody. So I specifically am highlighting submassive, so I'll go through all of that with all of you. By the end of this talk, I'd like us all to be able to appropriately classify PEs by their severity, identify possible opportunities for us to do CDT or catheter-based interventions, and then analyze CU's approach to how we handle submassives. It's an area of controversy that's been discussed since the early 90s. These are facts we're all pretty familiar with, but it may be news to you that it's the third cause of sudden cardiovascular death. And a lot of times patients don't present signs and symptoms of PE. In fact, most of the time they do not. But when they do, they will have potentially these things. And, you know, the lower two are more related to DVT, but it's something you should suspect. And I've seen our emergency departments regularly check for a PE, sometimes even in the absence of a positive D-dimer. But as he said, Dr. Schulich mentioned, we are under treating these, or they are over-occurring. Both of those things need to be addressed. There's a couple of different scores that we can use to help diagnose PE, because that's the first thing we need to do is diagnose the PE. And there are efficient and cost-effective ways of doing this. And you can determine the likelihood of a PE potentially before subjecting the patient to expensive and time-consuming studies. More than one tool exists. This is one of them. And if you notice here at the bottom, if the D-dimer is normal, it effectively rules out a PE, but it won't rule one in. Sometimes additional studies are needed. The PESI, the simplified index, is really straightforward. It just tells you if you're high or low risk. Literally 1 point will put you in the high risk category. And if you notice, a lot of these are the same things that put somebody at risk of a DVT. History of cancer is one of them. Simply being greater than 80 years old is a point. So the American Heart Association has tried to stratify PEs, and it seems simple, but there's still a lot of gray area in the middle category. The whole point was to be able to help us determine the best treatment strategies and to decrease death in patients. And non-massive PEs are basically also known as low risk. So they've got a normal blood pressure, both systolic and diastolic. Their troponins and BNP are normal. And then this is a big one. RV function on CT or echo is normal. So everything's just normal. And this may be a subsegmental, it could be a segmental. You can also use EKG. Submassive, you may have a patient whose vital signs are relatively acceptable, but their RV dysfunction or their troponins are concerning. And as I said, we're looking at cardiac biomarkers and then imaging to look at how the RV is in appearance to the left ventricle. And there's a ratio that we'll use to help diagnose PE. Massive PEs maybe are self-explanatory, and these patients are in shock. They're on vasopressors. So these three AHA categories are relatively straightforward. It's either everything's normal, things are abnormal, but the patient's not in shock, or they're in shock. And you do need to rule out other identifiable causes, and some of those might be musculoskeletal pain, pericarditis, mediastinitis, pleuritis, those types of things. But these patients have a significantly increased risk of death, especially within the first 3 months and when they're in the hospital. So everybody who has a confirmed PE, whether it's, with a VQ scan or a D-dimer that's positive and everything suggested, or a CT scan, they're going to get anticoagulation. But we know now that that's not enough. There have been studies since 1993 basically telling us that heparin alone is not going to cut it. They're going to get biomarkers drawn as well, and then sort of the more straightforward things. So there is a big push to merge the severity score from the AHA with the probability scores that I showed you, the systolic, the simplified index and the Wells score. So now we've got another classification system. And non-massive PEs, as I talked about, are low risk, and that seems obvious. These patients can usually go home, they'll get some Lovenox or a DOAC. But then this is the more complicated category. So there's moderate and severe moderate. And in a moderate risk patient, their oxygen sats are decreased. They're starting to show signs of pulmonary hypertension and all of the things I mentioned for prior patients diagnosed with a PE. They've got elevated biomarkers. They have RV dysfunction. And it's sort of a thin line that you cross when you get into the severe category. Now the patient isn't passing the eyeball test. They're starting to show signs of distress and a worsening EKG. And, to show that the RV dysfunction is progressing, you technically have to repeat imaging. So these are not always caught. And I find this to be an area where we can be more aggressive because, we tend to get one imaging study, or perhaps you get a CAT scan and then later you get an echo and you may see some discrepancy in how the severity looks of the right ventricle. And now we've been pushed into a category where we're acting. And I think vascular surgeons, at least the ones I've worked with in the past, who did a fair amount of PE catheter-based treatments, would treat the blue moderate risk category as well, depending on some of the criteria. You'll see a lot of emergency departments treating patients with what is now acceptable treatment for a PE. As I said, heparin is not appropriate unless it's somebody who can go home, they're low risk, and they go home on Lovenox. These submassive patients are going to get heparin to start with, or in my preference would be a big bolus of Lovenox, so they're immediately therapeutic. They're likely going to be admitted. And then a lot of the ERs are pushing 50 milligram boluses of systemic TPA or 100. And I will mention our prior practice we were at was really nervous to push 100. These are the patients that start jumping into the spontaneous intracranial hemorrhage category. 50 is considered a half dose, however. So 100 is the dose that is recommended if you're going to be doing something definitive. I will say all of you should make yourselves familiar with contraindications to TPA and lysis. It's a list of about 10 absolute and 10 relative contraindications, and there's plenty of people who just can't have this at all. The other practice also that didn't like TPA was in a trial for catheter-based therapy, so that had something to do with it. So again, merging these scores, we're now in the high-risk category. Massive PE falls into this. And the practices I've been more familiar with involved CT surgery from the get-go because these patients may need physical removal of the thrombus from the PA. So let's say it's now a submassive PE. Now what are we going to do? So we're in that gray area. And catheter-directed therapy, oftentimes in the literature, refers to just simply giving TPA through a drip. There are other things you can do over a catheter and a wire, however, and patients who have a high risk of bleeding might benefit from this. And the reason it's phrased like that is because this is a patient who maybe just shouldn't get a big 50 or 100 milligram bolus of TPA. So the thought is if you use a catheter and you drip it at 0.5 to 1 to 2 milligrams an hour only, that they would tolerate that better. Suction thrombectomy is out there. You don't necessarily need TPA at all. So that's an option for patients who can't have lysis. Pharmacomechanical, if you take out the pharma and you just do mechanical thrombectomy, that's a great option. And we're seeing more of that now. We'll talk about that in a moment. And then rheolysis is basically jets of saline with aspiration of the macerated thrombus. This is one of the options. These are a couple of the infusion catheters, and they are basically described to patients at the bedside like a soaker hose. They have side ports. The unifuse tends to be stiff, and I find it a little bit daunting to pass into the pulmonary artery. It can act like a harpoon and perforate. Any catheter can do that, but the McNamara catheters are much gentler. And as you would expect with TPA, these patients require overnight monitoring. Ideally, you're placing these catheter side port holes right inside the thrombus. So it's jammed pretty deeply into the segment branches. And you'll usually place one in the right, one in the left, and potentially a third access site for a Swan-Ganz catheter. And technique wise, the way we've seen it is in one common femoral vein, you'll put 3 6 French catheters. So this patient has all of these side ports coming out of one of their groins, and you put a PA catheter on each side and a Swan-Ganz on the other. And if the nurses are monitoring the A-line properly, you'll watch the PA pressure drop overnight as it melts away. It's pretty satisfying. Once a pulmonary artery pressure is significantly reduced or normalized, you can just discontinue the catheters right at the bedside. So they don't need to go back for additional imaging because it's of low utility. This is another option, and we're actually involved in a trial. The interventional radiology division is involved in a trial with FlowTriever, and the system on the left, it's a little bit hard to see against the purple background, but it looks like 3 Amplatz plugs sort of in a row. And you essentially insert this catheter into the PA, deploy these mesh cages, and then retrieve the thrombus. And they work pretty well. And it employs a 60 cc syringe on pretty high suction to try to pull the thrombus out as sort of like we call it the lollipop technique. The problem with these is you can lose wire access and have to start over. I think this new FlowTriever is going to be better. It's a little less bulky and its globular shape seems to be favored, I think, in terms of its safety. This is rheolysis, as I mentioned, and if you can imagine, these little side port holes jet out saline under high pressure with the idea being that you'll macerate the thrombus. That is then suctioned back with a Venturi-Bernoulli effect. And yes, some of this aspirates and some does not. So if you're doing this in the extremities, there is embolization on occasion, but this is an acceptable technique. One of the things that we have issue with is that this maceration often causes acute kidney injury, and it also can cause severe bradycardia, especially if you're right up near the heart. And of course you are if you're doing it in the pulmonary artery. So some of these patients will tolerate this for seconds and you'll watch their heart rate plummet. Penumbra is simply suction catheter. They've gotten bigger and bigger, and now there are 12 French available. And essentially you place it on suction after you've engaged the thrombus and try to pull it back. You have to be careful because you can exsanguinate these patients, but it's gotten better with what they call their lightning system, which has a quick on-off switch. And I think this is sort of the bane of everyone's existence because this takes a lot of meticulous maneuvers and time. This is not recommended. Angiovac requires veno-venous bypass. CT surgery needs to be involved. At our institution, that's mandatory if you're using any bypass system. And this is a really stiff, large bore suction device. If you can imagine coming from the IJ or the groin, you're going to be taking a couple of curves and putting torque on the ventricle, on the atrium and on the PA. So not ideal. I've seen one case and everyone was sweating, and interventional radiology and CT surgery did it jointly. The thing about this though is if we do more than simply just giving people systemic TPA, then we've increased their survival. And the primary goal is to reduce RV dysfunction and improve gas exchange. We have a PE response team here, and many institutions have them. Sometimes it involves an overhead alert or a pager alert. It's often involving at least 3 of the specialties listed there. Ours involves pulmonary critical care, interventional radiology, interventional cardiology, and the ER. And Dr. Huntress, Peter Huntress, is our director currently. I think the thing to point out with this slide is that there are providers capable of performing CDT, but as you dig into the numbers at this institution, you'll find it's not being utilized as heavily as I think it should be. We do need more data for that though. So our protocol is dictated both by how the patients present with all the data that we just talked about, how their cardiac biomarkers look and their imaging, really looking at RV dysfunction, how it compares in size on CAT scan to the left ventricle, how it looks on the echo, and then a discussion. So it's an expert panel talking about what we should do in the ER. And a lot of times by the time that discussion is had, somebody's already pushed 50 to 100 milligrams of TPA. And it's pretty nice when it works. When it doesn't, it can get, the interventions can be more involved. So again, submassive PEs have been a gray area for a long time. And the most daunting complication, as you can imagine, would be major bleeding. And that can be intracranial, intraspinal, intraocular bleeding, things like that. So a drop in hemoglobin requiring transfusion would be considered major bleeding. And I think everyone just shies away from this, but I think it's interesting how quickly systemic boluses of TPA are pushed. We know that heparin's not sufficient. We know that the trial for advocating for 50 milligrams is poorly structured. There are lots of trials I can give you data on. With catheter-directed therapy, I think there's enough data to move forward so that we're doing it more regularly. Most of the time when people hear catheter-directed therapy, at least with the interventional and pulmonology groups, they're thinking about whether or not we're going to use the side port catheters that I talked about that look like soaker hoses. I think we're starting to move into some of these mechanical thrombectomy trials, and people are hoping for really good data. Essentially, these very convincing trials, these are the 3 largest prospective trials that have been done, which is great. They're not retrospective. And these are showing that they rapidly restore RV function. And I think that's a pretty strong argument for using them. The bleeding risk in these cases is less than 11%, which has actually been showing more promising numbers than traditional boluses of systemic TPA. So ECHOS is a catheter that you place in the lung, but it also involves ultrasound. I'm not a big proponent of it, but the data advocates for this. So, you go with what the data shows. It's same method that you would use with the Unifuse and McNamara catheters, but the problem with this is that ECHOS is industry driven. And so the trial, you have to take it with a grain of salt, but the data is not also very strong. And so groups, including ours, have taken issue with us just jumping straight to catheter directed therapies rather than simply giving it through the IV and watching patients recover in the unit. We're currently in an exciting trial. Interventional radiology is participating in the Peerless study. And we're one of 550 participants, which I think is exciting. It's a big trial. Inari Medical is industry driving this. And this is pushing for us to use mechanical thrombectomy. And as you can imagine, there's pretty big advantages over somebody who can't have TPA at all. So now there's this option that doesn't require systemic thrombolysis or catheter-directed thrombolysis. And the great thing about these is they're not going to be necessarily staying in the ICU overnight for TPA. These patients are on the table once, you debulk the PA thrombus and you get out. I think some things that we should consider would be the most important being that RV dysfunction increases death. Within the first 3 months, everyone's kind of holding their breaths. I've watched patients go home, even from RER on oxygen. I think, from the eyeball test, it's sort of disheartening to watch that. Sometimes I've seen them in follow-up and they're still on nasal cannula oxygen. And I think more could have been done. But again, we need data to support that. These biomarkers and imaging are going to dictate our interventions until we have something more promising. And I think we need to be open to the idea that interventionalists should be one of the first priorities in terms of how these are managed. Sometimes the ER and the pulm critical care are taking care of these patients alone because their algorithm sort of stops short. But I do think that interventionalists should be on every conversation. And this is a multidisciplinary approach. So we're hoping surgery plays a bigger role in the future. Currently, we're sort of waiting for catheter-directed therapies to become more of a player. And then I think we'll expand our team. There's ongoing discussions, which are really exciting right now. Thank you, everybody.
Thank you, Dr. Malgor. So let's kind of narrow the scene a little bit. So most of us are going to be taking care of a post-op patient who is, day 0 to 2 weeks post-op. When should we give you a call or call the PE team? Here, you can use this.
That's a light, right? I mean, as soon as you suspect it, if you've got leg swelling, I'd prefer you call us, but it's just my preference. But I think early on, because the proper studies can be done. And now that you all know what to order, you can help expedite that. But this is where the non-TPA therapies are going to be excellent because you can't use it. Yeah.
Questions or comments? Dr. McIntyre?
Doing a surgical embolectomy, or has that completely been put into obsolescence because of all the catheters?
Definitely a role. It's pretty rare. I've seen it twice at another institution, and they're so unstable. You have to imagine these cases that we do with the catheters. The patients are awake typically because if you sedate them, their vitals will plummet and become unstable. So I've seen a patient on the table crying for help. They had that sense of doom because they were literally just about in the massive category. We were about to put them on pressors. And that's when I like CT involved. And it's aggressive, but it's a sternotomy. They go right in. So I think there's a role for it. You can't put those people on an open table with almost no sedation. And there's almost nothing stabilizing them.
It's the Trendelenburg procedure. Right. Yes.
I think CT surgery's involvement will be a lot less with these large catheter and aspiration techniques, because you don't have to get every bit of it out. You just have to make them a little better, and then they're stable. Then you can take time to maybe clean it up with lysis if they can tolerate some TPA. But the angiovac was the thing that was to replace open thoracotomy. But placing that, you can aspirate lots of blood because you're just giving it back, through the pump. But manipulation of that device in the lung is not simple. And now we have large catheters that are pretty efficient with not sucking out a lot of blood and really do the same thing. It's not a matter of gratifying pulling out that huge clot. It's really just improving their hemodynamics that gets them better enough. And a thoracotomy at that instance, the mortality of that is significant.
I think stability is everything. They have to be stable enough, right?
I think they're behind you are a couple of questions.
Dr. Malgor, thank you for a wonderful presentation. Of course, I'm biased since you're in our department. But my question is, I feel like more often than not, the patients that we tend to be notified about PE or the interventional radiology department is I feel like more often than not, the patients that are often identified with PE, at least when we're involved, are patients with, multiple pathologies admitted to the ICU already. And based on the risk stratification score, they're often empirically treated for PE. And they're already on pressors for various reasons. If we are in such scenario where they're being empirically treated because they're either unstable or not, but prior to us engaging in any of these endovascular procedures, is imaging paramount, or just like they start anticoagulation empirically, do we also empirically take them to the operating room? Because I always hated taking a patient to the operating room without any imaging?
Yeah, I mean, I'd be hard pressed to take somebody if I don't suspect a PE, and you might get a positive D dimer from just about anything. They could have a small lysing thrombus somewhere. I do think it's worth getting CT imaging or an echo bedside first, just to confirm before you take them on the table. And yeah, if they're already intubated, and even if they're on vasopressors, at least they have a secure airway. You could potentially do it that way rather than an awake patient who, if they go on pressors, now they're becoming unstable. Now we're intubating them, et cetera. I think in that situation, you kind of already have a safety net in terms of having a protected airway and being able to treat shock. I would still do catheter directed for that. Yeah. And that's sort of kind of what Dr. Schulich was saying in these, we have a lot of post-ops where it just gets more complicated. Yeah.
Okay, last question or comment? Last one. Was there one? No, you're done? Okay.
Thank you.
Great. Thank you very much. Great job.